see.
Okay, so everyone's in. Dr. Deshmukh is here. Is Dr. Banayat here? Dr. Qureshi is here. Okay. Good evening. So to all the audience, we'll be going live in a few minutes. We are just waiting for all the chairpersons to log in. In the next 1 or 2 minutes, we'll start the session. Vikram, if Vikram is there, can you check? I think Dr. Gedam and Dr. Banayat have not logged in yet.
Sir, I have forwarded mail to Dr. Banayat and
Dr. Gedam tells me that he will be joining 10-15 minutes later. We can start without him. How about Dr. Atish and Dr. Paranjpe?
I'll call Dr. Atish, sir.
डॉक्टर बानाईत अजून आले नाही आहेत. सरांना एकदा फोन लावून पाहतो.
सर लॉग इन करो ना.
हेलो हेलो
Okay, so I
Hello?
think, yeah, is the administration here? Okay, good. So, Dr. Deshmukh, to me, just log out of your phone, na, Abhijit sir? Because if you log in from
I'm
both
logged
phone
out
and there'll be
of my
echo.
phone.
Speaker chilling.
No, I am out of my phone connection.
Yeah, now the echo is gone.
Yeah.
Should we start? Abdul, are you here?
Yes, sir. Can you hear me?
Yes.
You're here.
Okay,
Actually,
right,
I wanted that the link, the chairpersons and speaker link be forwarded to President Secretary of ASN as well as Digestive Diseases Society. So I'll request Vikram or the organizers to send the link to Dr. Paranjpe and maybe Dr. Atish Bansod and Vikram Desai. We'll just wait for a couple of minutes.
Already late.
Huh? 7:36. Should we start?
Yes, we can, I think.
Okay. The boss has come.
Good evening, sir.
Good evening, friends. It gives me immense pleasure to welcome you all for this novel webinar, which I would say, of landmark papers in gastroenterology, endoscopy, and surgery, GI surgery, of course. So, because of, I was planning this topic for the last 4 or 5 months, but because there was a flood of webinars ultimately we decided to postpone it to a couple of months. So it got postponed for 4 to 5 months. At the outset, I must express my sincere thanks to the President and the Secretary of ASN for collaborating with MIDAS and as well as the DDS, Digestive Diseases Society. Of course, Dr. Paranjpe is the secretary. He is probably logged in. And a sincere thanks to Dr. Paranjpe and ASN. And my special thanks to Dr. Vinky Rugwani, who has done a lot of efforts for approving this webinar for credit points. So all those who are logged in should put their registration numbers so that they will be entitled for 1 credit point. I think CME is the need for the hour, and it is necessary that one should get updated in the various latest things which are there in the field which you are practicing, which accounts for better patient management. And what we have selected is articles from a very reputed journals like New England Journal of Medicine, Lancet, Gastroenterology, GI Endoscopy, and so on and so forth. So they are all reputed articles. Most of them, they are the RCTs, randomized controlled trial, prospectively conducted, double-blind or maybe non-blinded, but those are all scientific articles. So what we plan to discuss is we discuss in 3 legs. One, upper GI, where the articles pertaining to upper GI will be presented by me, Dr. Saurabh and Dr. Yogesh. Then pancreatobiliary articles, again in the same sequence. And lastly, we will take lower GI, metabolic, and other articles which are important. Since there are many articles, I request the chairpersons to control the time, and it would be good if one topic is done, then it can be discussed out in details. After discussion of each of these sectors, we can have a question answer. And with this, I hand over the mic to Dr. Atish Bansod. Dr. Vikram Desai is not there. So Atish is the Secretary of ASN to welcome on behalf of ASN.
Thank you very much, Mukhtar sir. A very good evening to you all. Respected persons, Dr. Abdul sir, Dr. Gadam sir, Dr. Abhijit Deshmukh, Dr. Vaibhav Banait, Dr. Saurabh and Dr. Yogesh. I welcome you all on behalf of Association of Surgeons Nagpur, MIDAS Medical Foundation and Digestive Diseases Society. So today we are going to have a very interesting session. And the session would be discussion regarding important papers, various papers regarding what is new in endoscopy and ERCP, which will be spoken by Dr. Mukhtar sir. Then recent important articles in endoscopic ultrasound and third space endoscopy by Dr. Saurabh Mukhtar. And a third aspect would be recent important articles in surgical gastroenterology by our very own Dr. Yogesh Bang. And after that, we will be having a discussion and video presentation of interesting cases. So I thank everyone who has joined for today's event. And I would hand over the mic to our respected chairpersons, Dr. Gadam sir, Dr. Abdul Qureshi sir, and Dr. Abhijit and Dr. Vaibhav to start the proceedings of today's evening. Thank you.
Shriram sir, you can start.
I don't know. I think Shrikant Mukhawar is going to speak first on upper GI. So, Shrikant, I think we can start your paper presentation.
Sure.
The only request is we don't know what time is allotted to each lecture. I suppose everybody who speaks knows how much time he has at his disposal. I think you all know your time yourself.
So, sir, I think what we have done is we have created sections. One is upper GI, and speakers will take turns to discuss the articles. So it's not limited to one person speaking all the articles and the next person.
Okay.
We all will be taking turns, but we'll try our best to ensure that it's not beyond time.
Sure.
Okay. So we can start. 1 second. Okay. So we will start sharing our screen in a second. All right.
Can you see the screen?
Yes.
Yes, sir, we are in. Yes, we can see.
Okay.
Basically, will be discussing, as I said, landmark papers in gastroenterology. The first one is upper GI. This is one of the articles published in New England Journal of Medicine, October 2019, randomized trial of medical versus surgical treatment for refractory heartburn. There's a lot of noise. Can somebody take care of that?
I think, Dr. Chairpersons, can you please mute your mic? Because I think the echo is coming, if you don't mind.
Yeah.
Please, everyone. Thank you.
Thank you. So this is a randomized trial of medical versus surgical treatment for the refractory heartburn. So the refractory heartburn is not uncommon in clinical practice. It is said that in spite of PPI, but 30 to 40% of people with reflux, they don't get symptomatic relief. Persistent heartburn, in spite of omeprazole 20 milligram twice a day, 20 minutes before meals for 2 weeks, was defined as it should be 30 minutes before meals for 2 weeks. So that was defined as persistent and refractory heartburn. The options of treatment for such patients are either you use a medicine like baclofen, which is a reflux reducing medicine, or you add something to reduce visceral sensitivity like antidepressant in low dose like desipramine, or anti-reflux surgery. So these patients who were referred as refractory heartburn were divided into 3 arms. They were randomized to surgical treatment in the form of laparoscopic Nissen's fundoplication, active medical treatment in the form of omeprazole, baclofen, and desimipramine, and a control medical treatment in the form of omeprazole per placebo of baclofen. Desimipramine was used in the active treatment whenever is clinically indicated. So the primary outcome of this trial was to know the decrease in more than 50% of GERD-related quality of life scores at the end of 1 year. So you can see there were 366 patients who were referred for those who were not better or those who did not have more than 50% relief after 2 weeks of omeprazole 20 milligram twice a day taken on empty stomach 30 minutes before meals. Out of which 366, only 20%, 78% patients were randomized, because patients, they underwent endoscopy, esophageal biopsy, manometry, pH studies, and surgical consultation. So they were extensively investigated. The point of emphasis here is 80% of the patients were excluded because they had functional heartburn. They had other causes for burning in chest like cardiac disease, achalasia, or they responded to proper dosing of PPI. So 20% of the patients, like 78, were randomized to surgery, active medical treatment, and control medical treatment, only form of PPI. Quarterly review was done, 1 year evaluation was done. And these are the results. This is the first randomized controlled trial of patients with anti-reflux surgery and GERD. By and large, surgery is not favored, but this particular study has shown that 67% of the patients in anti-reflux surgery group responded as suggested by more than 50% improvement in GERD-related, health-related quality of life score at 1 year versus 28% with medical line of treatment versus 12% with only omeprazole. So adverse effects were similar. So the message of this trial is anti-reflux surgery is superior to medical therapy for refractory heartburn. And this has been shown. You can see the difference in the bar diagram that more than twice patients responded to surgical treatment. Unfortunately, with us, the surgical treatment for GERD is not very commonly used, and therefore, this is maybe a turning point in our practice. 5 mechanisms for PPI refractory heartburn. One is abdominal acid reflux despite PPI. So they have acid still there. The second is reflux hypersensitivity, heartburn to physiological acid. Third is motor disorder of the esophagus like achalasia. Sometimes they present with heartburn. Fourth is extraesophageal disorder like cardiac disorders. And lastly, is a case which is a functional heartburn. Many of these patients had functional heartburn. By functional heartburn, I mean they have a normal acid, they have a normal endoscopy, normal biopsy, normal motility. So they are the patients with functional heartburn. It is said that surgery would work for number 1 and 2, that's abnormal acid reflux and hypersensitivity group. So that's article number 1. The message is patients with refractory heartburn are much better if they are offered anti-reflux surgery than the medical line of treatment when prospectively evaluated. The patients with severe reflux were excluded in this study. Now, the second article which I am going to discuss is timing of endoscopy for acute upper GI bleed, again published in April 2, 2020. This is mainly from Joseph Sung group from Hong Kong. So they have a lot of papers on upper GI bleed. Most of the patients with upper GI bleed undergo endoscopy within 24 hours. This paper was to define the role of urgent endoscopy as defined by endoscopy between 2 and 12 hours. Earlier, some of the RCTs and observation studies have not shown benefit and does not decrease the mortality, but the numbers were small. So here they have put 2 groups, urgent endoscopy that is within 6 hours and early endoscopy within 24 hours. So their main intention was whether the urgent endoscopy done helps in reducing the complications and mortality as compared to early endoscopy done within 24 hours. Now, this is the baseline characteristic of the patient. Most of the patients were matched. As you can see, 258 patients in the urgent endoscopy group and early endoscopy group within 24 hours were 258 patients. So there were significant number of patients. Most of them were matched. They had a Glasgow Blatchford score of majority had 12 to 14, 74.28%, about 3/4, and 15 to 23, around 1/4. The coexisting disease like ischemic heart disease, cancer, cirrhosis were matched. Majority of them, they had peptic ulcer. And the point to be noted was varices were present in less than 10% of patients, which normally is not the case with us. The time from the presentation to endoscopy. So they have different time from presentation to gastro consultation was 7 hours in urgent group and 8 hours in early endoscopy group. But the time from presentation to endoscopy was still 9.9 hours versus 24 hours. So that I want to highlight because the other points are not relevant. the cumulative probability of death was more once you have an urgent endoscopy. So urgent endoscopy is associated with more probability of death and more probability of further bleeding. So the primary endpoint was death from any cause within 30 days, which was higher in urgent endoscopy group, 8.9 versus 6.6, hazards ratio of 1.35. And the further bleeding within 30 days was again more in the urgent endoscopy group, the hazards ratio being 1.46. I would not go into the details of other points. Why increase risk in urgent group? Better care of comorbidities before endoscopy were done by acid suppression. If you get some time, what happens is the better care of comorbidities are done. The acid suppression reduces endoscopic interventions. The limitation of the study was patients who are in shock having severe GI bleed were excluded, and varicose hemorrhage are the patients are small number, less than 10%, where maybe urgent endoscopy may be useful, more useful. So it may not be applicable with the areas of high prevalence with portal hypertension. So that ends my 2 talks. So the message, I will just repeat, anti-reflux surgery has been better as compared to conventional medical treatment for refractory GERD. Second, urgent endoscopy is associated with more mortality and more bleeding, rebleeding than the early endoscopy. Early endoscopy. So it's better to stabilize the patient and then do the endoscopy. As that's a message for this. Now I think the Saurabh should take over.
Okay. Let's see. My face is visible. Fine. Okay, so hi, I'll be talking about a couple of papers. I'll just give a background on achalasia. Achalasia is a disorder secondary to inability of the lower esophageal sphincter to relax, resulting in dysphagia, regurgitation, and weight loss in patients. Different types of achalasia, there's type 1, 2, and 3 based on manometry findings. Type 3, which is the more difficult one to treat, associated sort of esophageal motility issues. The response to therapy for achalasia is variable with traditional treatments with Botox having very low efficacy of 40%, 50% with balloon dilation, and myotomy surgically about 85%. And we'll talk about POEM procedure today in few of the papers. So the POEM is a new procedure in which is per oral endoscopic myotomy, which is performed endoscopically, in which entry is made into the mucosal space, followed by myotomy performed endoscopically, followed by closure. I'll just show a brief video to illustrate the procedure, as this is what we'll be discussing today. For people who are not familiar with this procedure, this is just an illustration. I'll be quick in presentation. So we make a submucosal incision, and right, mucosa is, there's an incision made in the mucosa. Move forward. And in the submucosal space, gentle dissection is performed to enter the gastric side. So this is the tunnel that's been created in the submucosal space. And then eventually the muscle is cut with the help of endoscopic tools, which is called myotomy. And I'll just move forward. So this is how the muscle has been cut. And in the entry side is closed with multiple clips. All right. So the advantages of POEM are felt to be that there's a lack of any incision, rapid recovery. Patients often are discharged the following day. You can create a long myotomy in these patients because you have the ability to do so, which is not possible by other modalities. Can be performed in the anterior or the posterior manner. So if patients had fundoplication anteriorly or myotomy, then you can do posterior POEM. It's high efficacy. So with that, we'll talk about a couple of papers. This is a New England Journal of Medicine paper published last year comparing endoscopic or surgical myotomy in patients with idiopathic achalasia. This study was performed, it's a prospective, multi-center, randomized, open-label, non-inferiority trial performed at 8 centers in 6 European countries. Basically, patients above 18 years of age with Eckardt symptom score, which I'll show you in a few slides, over 3, and manometry consistent with diagnosis of achalasia were included. Other patients who had undergone surgery, etc., were excluded. Patients who had undergone endoscopic treatment were not excluded. So the people who had balloon dilation also in the past were included in this trial. All right. So basically 241 patients underwent randomization, of which 120 were assigned to the POEM group and 121 to the laparoscopic Heller's myotomy group. Few of them were excluded for various reasons. And ultimately 108 in the POEM group and 103 in the laparoscopic Heller's myotomy group were included. The baseline characteristics in between the two groups were largely not different, with median age of 48.6. Achalasia subtypes were more or less evenly distributed between the 3 groups. It's important to note that because type 3 achalasia is generally not the easiest to treat. So the distribution was similar between the groups. And Eckardt score was also 6.8 plus minus 2, similar. All right. So just to show Eckardt score what it is, this is the 4 parameters which are considered: dysphagia, regurgitation, chest pain, and weight loss. And the scoring is given from 0 to 3. So any patient can have a maximum score of 12 or a minimum score of 0. Generally, a total score of less than 3 is considered as the goal of any successful treatment for POEM. So between the 2 groups, clinical success was achieved in both the groups in a similar manner. At the end of 3 months, 94.6% in POEM, 89% in Heller's myotomy. At the end of 2 years, 83% in POEM and 81.7% in Heller's myotomy. Numerically, there was a marginal difference in POEM and Heller's myotomy, but more or less similar. Based on esophageal manometry, which measures the integrated relaxation pressure in the lower esophageal sphincter, there was no difference between the groups in terms of its effectiveness. The GI quality of index was similar. Rate of serious adverse events was 2.7% in the POEM group, 7.3% in the laparoscopic Heller's myotomy group, which is numerically more. The study was not designed to determine statistical significance, but there were no deaths in the study. The rate of GERD, which seems to be the main problem with any of these interventions, because you're basically incising the muscle, which will enable all the gastric contents to come up in the esophagus. Overall, pretty high at the end of 2 years, 44% in the POEM group and 29% in the surgical group. And then the esophageal acid exposure time was also similar between the 2 groups. But if you see significant reflux as defined by LA grade C or D was basically similar between the 2 groups from what was available, nearly 30%. And as illustrated in this figure here, baseline, very little reflux. Following POEM and Heller's myotomy, in both the groups, there was a significant amount of reflux, more in POEM than in Heller's myotomy. This is much higher than what's been shown in the previous studies, where about 8% symptomatic reflux has been seen and 13% esophagitis on EGD, although they seem to have more abnormal acid exposure time. This is a meta-analysis of, I think, 1,000 plus patients. All right. So bottom line, POEM is non-inferior to Heller's myotomy. Overall success rates lower in the trial were felt to be either because of including patients with failed prior therapy. Almost a third of patients had either botulinum or a balloon dilation. More serious adverse events were seen in the Heller's myotomy group than POEM. More GERD in POEM than in Heller's myotomy. The limitations were less than 50% eligible patients participated in the trial because the consent was not given. And the surgeons were more experienced in Heller's myotomy than endoscopists in POEM. All right, I'll move to the next study. This study compares effect of POEM versus pneumatic dilation on for patients with achalasia. And these are treatment naive. So none of these patients had any prior endoscopic treatment, which is different from the earlier trial, where a third of patients had some sort of endoscopic treatment. This was published in JAMA in 2019. Again, the population consisted of 73 men and 57 women, mean age of 49 years at 6 international sites. 67 patients underwent POEM, 66 pneumatic dilation. Primary outcome, as outlined in the earlier study, was Eckhart score less than 3. And just the bottom line here, POEM 92% success versus pneumatic dilation 54%. We'll get into the granular details here. On the left is the baseline characteristics between the two groups, basically very similar. Type 3 achalasia was more common in the POEM group, which is more difficult to treat, as I mentioned, 20% versus 10%. In terms of the flow chart, 182% patients were evaluated, about 50 were excluded, 133 were randomized, 67 in POEM, 66 in pneumatic dilation. Bottom line, most of these ended up in the trial. So treatment success, as I outlined earlier, at the end of 2 years, 92% patients with POEM achieved the treatment goal versus 54% with pneumatic dilation, and similar findings at 3 months or 1 year. Going back just to illustrate this in a different diagram, on the left here is the POEM group, where Eckhart score mentioned here in the left in the y-axis. Out of the 63, 58 achieved the target, as you see here, from baseline of 11 going down to baseline to 0 or 1. And this was achieved, as I said, in 58. 5 patients, they did not achieve success with POEM, and I'll describe what happened to these patients. On the other hand, with pneumatic dilation, 34 of the patients achieved the Eckhart score as described, but in the remainder 29, this was not achieved, and 1 patient had a complication, that's perforation, and for that reason was considered a treatment failure. So looking at treatment failure in pneumatic dilation, unsuccessful in 29 patients, as I outlined earlier, which is about half of those patients included. 23 required additional treatment with pneumatic dilation, and 3 declined, 2 received POEM. For those 23 which required second pneumatic dilation, recurrent symptoms developed again in 9 patients who then underwent POEM. So POEM was unsuccessful in 5, 4 all of these underwent pneumatic dilation, which was successful in 4 of the 5. That's 80%. So, but adverse events rates, POEM, the reflux esophagitis, was more frequently seen in POEM because it's more effective with 41%, but 6% in, 41% versus 7% in pneumatic dilation. Perforation, 1 case in pneumatic dilation group, no serious adverse events in the POEM group. So bottom line, POEM was more successful than pneumatic dilation for treatment of achalasia. Reflux esophagitis was more commonly seen in POEM than pneumatic dilation. Lower success rate in pneumatic dilation since only 1 session of dilation was compared to POEM. This is what the authors felt, that this is only 1 session done. Oftentimes patients require 2 sessions. But even if you were to consider 2 sessions of pneumatic dilation, the overall success was still lower than POEM, which is 76% versus 92%. I'll just share with you our experience. We have started doing POEM at Midas for the last about year or so. We've done 23 e-POEM, that is esophageal POEM cases. 12 patients have come back for follow-up. The others are pending follow-up as of now. Pre-POEM Eckhart score was 8, which was a median. Post-POEM Eckhart score was 0, although some had 1 or 2 or 3. But percentage of patients with POEM Post-POEM ECART score less than 3 was 100%. All of them achieved the success, the targeted ECART score. GERD was seen in 3 of our 12 patients on follow-up. We're still awaiting 11 patients follow-up in our experience. Serious adverse events included 1 patient with capnothorax, which required CPR, although we stopped the procedure. But the patient was eventually recovered and was discharged home. 1 patient had a high cardiac risk requiring and developed MI, but then eventually recovered and was discharged home. So that was our experience. And before we switch to pancreatobiliary, I will stop sharing. And Yogesh, if you can log on and share your presentation, please.
So good evening, everyone. I will be sharing my screen now. So landmark papers in GI surgery, that is what is my topic. I'm sorry, I'm not going to talk on the recent one. I have some recent one, but I'll be discussing more of the papers of GI surgery, which have changed the way we treat some of our surgical gastroenterology diseases. I'll be sharing my slide now. So my teacher, Dr. Qureshi sir and Gedam sir are there as a chairperson. I'm sorry, Qureshi sir, I have presented you Journal Club as a resident. I'm not going to present exactly the way I used to present that time. So pardon me for that. So landmark papers in GI surgery, what we are going to discuss is management of carcinoma stomach. I'm going to go through 2 or 3 papers in which I'm going to tell how we have evolved in the management of carcinoma stomach, how we have evolved from surgery, then adjuvant chemo, and now the treatment of choice, which is perioperative or a neoadjuvant chemotherapy. So what are the papers which have made us come up to this stage? That is what I'm going to discuss now. So surgery for carcinoma stomach has always been debated topic, whether you need a D1 gastrectomy or a D2 gastrectomy. Now this debate between D1 and D2 is mainly because earlier it was mainly because D2 gastrectomy was known to have a more morbidity and more complications. D1 gastrectomy was predominantly being done by D2 gastrectomy was predominantly being done by Japanese surgeons. The incidence of carcinoma stomach in East is far more. So they were very well trained in D2 gastrectomy. Their D2 gastrectomy always involved distal pancreaticosplenectomy along with lymph node retrieval of all the perigastric and major vessels around the stomach. While on West, where the incidence of stomach malignancy was not high, they always preferred D1 gastrectomy considering the overall morbidity and mortality. So the understanding of these D1 and D2 was significantly changed with the Dutch trial, then MRC trial from England and Italian gastric cancer trial. I'll be discussing a few topics about those. So what exactly is D1 and D2 gastrectomy? Just a brief about that. In D1 gastrectomy, along with stomach, we remove all the lymph nodes along the stomach, perigastric lymph node. These are labeled as N1 group of lymph nodes. So these are basically right and left paracardiac lymph nodes. Then there is a lesser curvature lymph nodes, greater curvature lymph nodes, 4, suprapyloric 5 and infrapyloric 6. So removal of these group of lymph nodes along with the malignancy is considered as a D1 gastrectomy. Anything more than that, that is lymph node along the left gastric artery, that is 7, then lymph node along common hepatic artery 8, celiac artery 9, splenic artery 10, 11. These are considered as N2, or these are the lymph nodes. If you remove these, then you go up to D2 gastrectomy. So earlier, before like 95 or 96, D2 gastrectomy always involved removal of pancreas and spleen. And that was the reason why the morbidity in D2 gastrectomy was very high. So this was the first paper by Dutch people in which a randomized comparison between D1 and D2 dissection was done. It was presented in 1995. Nearly 1,078 patients were randomized into D1 and D2 gastrectomy group, and curative resection was possible in 380 patients in D1 group and around 331 patients in D2 group. When you look into spleen resection and distal pancreatectomy in D1, 10% of the patients had underwent splenic and 3% had underwent pancreatic resection. The mid-body tumors which were locally advanced, they had to undergo this resection, and around 40% of the patients underwent distal pancreaticosplenectomy in D2 group. What they found, this was actually, this was published in 95. Immediately as soon as their study was finished, they didn't look into survival in this. It was only a morbidity which they looked into it, and what they found was morbidity or death was significantly higher in D2 group as compared to D1 group. So what they said, while we await survival result, D2 dissection should not be used as standard of care. This was way back in 1995 when D2 resection always required distal pancreaticosplenectomy, and that is why the morbidity and mortality in this study in D2 group was far more. Now, the same trials, the same patients, they came up with the survival result in 2004 in Journal of Clinical Oncology. What they said that there is no long-term survival benefit from extended lymph node dissection in Western patients with gastric cancer. Now, why this statement came up? Because the morbidity and mortality in D2 group was very high just immediately after surgery. And when they followed these patients for 9 years, after 11 years, when they published this result, the overall mortality in both the groups was nearly same. The result, the reason being morbidity, the mortality at the time of surgery was more in D2 group. But there is one important caveat which they mentioned here for patients with N2 disease, that is the patients who have lymph node along the major vessels, extended lymph node dissection may offer cure. So that is what D2 gastrectomy says. If you look into the charts carefully, so this B and C are basically the lymph nodes, N2 and N3, the lymph nodes along common hepatic artery, lymph node along left gastric artery, the major gastric vessels in which D2 gastrectomy is done. The survival is better with D2 gastrectomy when you have lymph node positive disease. So this was the chart B, and this is N3 lymph node. When the lymph node had gone up to para-aortic or the base of mesentery, they said that survival is better with D2 as compared to D1. So these 2 points made people go ahead with D2 gastrectomy further. When they came, the same group came with 15-year follow-up of these same patients. What they found was D1 had far better survival, D2 had far better survival as compared to D1. At 15 years, when same patients were followed up, so they found that survival in the death due to gastric cancer is far more in D1 as compared to D2. This is what the conclusion was at 15-year follow-up. So after 15 years, they said that D2 lymphadenectomy is associated with lower locoregional recurrence and gastric cancer related death than D1 surgery. D2 was also associated with higher post-operative mortality, morbidity, or reoperation rates. But then this was the line which they added, a safer spleen preserving D2 resection technically, which is currently available. This was in 2010. D2 lymphadenectomy is recommended approach for resectable gastric cancer. So based on this, we have come up to a stage where D1 has now evolved into D2. We don't remove routinely the spleen and pancreas for all the patients of carcinoma stomach now. And that's why our morbidity and mortality has come down in the comparison with D1. It's nearly the same, and survival has significantly gone up. Coming to this second MRC trial, again D1 versus D2, which they had compared 200 patients in each arm, D1 200 and D2 200, and at end of 5 years, nearly 172 patients survived in D1 and this D2 186, which were compared. What they found was the survival was nearly same, 35% and 33% in D1 and D2 group. But if you look at this point exclusively, which I have marked, in D2 group where distal pancreaticosplenectomy was not done, the survival was 46%, far better than the D1 group. Again, the same point which they have mentioned, that if you don't remove pancreas and spleen and you do D2 gastrectomy, the survival is better. In this chart where you can see, this is the uppermost chart, uppermost graph in which D2 gastrectomy was done without removal of pancreas and spleen, and the survival was better with comparative to all other groups. So they say that classical Japanese D2 resection offers no survival advantage over D1 surgery. That is true, but then possibility of D2 resection without pancreaticosplenectomy may be better than standard D1 resection. And that is why we have now moved on to D2 resection without removal of pancreas and spleen. And that is how end result of D2 gastrectomy looks.
Post-op video of a radical gastrectomy anatomy. You can see this is portal vein. This is right gastroepiploic vein which is ligated here. Then we go on to right gastroepiploic artery. This is right gastroepiploic artery. Okay. From here you can see the gastroduodenal artery going up here. Gastroduodenal artery forming common hepatic artery here, and the left hepatic artery there. Here we have ligated right gastric artery up. This is the ligature of right gastric artery. Right? From there we have come down on common hepatic artery here. So this is left gastric artery, common hepatic artery, and splenic artery. These are all three branches of celiac artery. So celiac artery is also completely clear.
So that is the complete skeletonization of all the vessels which we do in D2 gastrectomy. And you can see here, this is the Mercedes-Benz sign which is seen once you clear off all the lymph nodes along common hepatic artery, splenic artery, and that is the left gastric artery which we have ligated, and the origin of celiac artery also being cleared up.
Of all the lymph nodes, and this is aorta. Okay, these are all small fibrotic tissue remaining, but I am not going to take these. Now below this is portal vein. Okay, here in portal vein, this was the left gastric vein which was going in. This is proximal splenic and distal splenic being cleared off the pancreas. Now you will show you the stomach. This is the lesser curvature of stomach which was completely cleared of all the lymph nodes, and this is the greater curvature.
So that is how we have evolved from D1 to D2 gastrectomy for management of carcinoma stomach, and that is the standard procedure or standard practice now. Now, added to our surgery is a chemotherapy. What has been seen in most of the malignancies is nearly 35 to 40% of the patients are the patients who complete their chemotherapy after surgery. The adjuvant chemotherapy, which is required in most of the patients, only 35 to 40% of the patients complete that. Now, malignancy is treated nowadays as a systemic disease. So the concept of giving chemotherapy before surgery has come up considering these two aspects. First, to treat the systemic disease from day one. And second, as many of the patients don't take chemotherapy, so better give them systemic chemotherapy beforehand, decrease the bulk of tumor, look into the tumor biology, how it is reacting, and then operate. So this was the study which was published in NEGM in 2006, in which perioperative chemotherapy, that is 3 cycles before surgery, then surgery, and 3 cycles after completion of surgery was proposed. And they did this randomized trial in which perioperative chemotherapy versus surgery alone for resectable gastroesophageal cancer or gastric cancer was done. So they used 3 cycles of ipirubicin, cisplatin, and 5-fluorouracil before surgery, and they compared 250 patients in perioperative chemotherapy group versus surgery alone of 253. So in this group, nearly 185 patients had stomach malignancy and 187 in the surgery only group had stomach malignancy. And curative intent surgery was done for nearly 169 patients in chemotherapy group followed by surgery, and 166 patients in surgery only group. What they found was, after giving perioperative chemotherapy followed by surgery, the progression-free survival and overall survival was far better as compared to surgery alone. So they came up with conclusion that perioperative chemotherapy with a regimen of ECF improves overall and progression-free survival among patients with resectable adenocarcinoma of stomach, lower esophagus, and GE junction. This treatment should therefore be considered as an option. In 2006, they presented this, and by 2011-12, we had many papers which established this very well. And then in our NCCN guidelines, ESMO guidelines of malignancy, we started seeing a routine usage of perioperative chemotherapy for malignancies of stomach. Recently, in 2019, in Lancet, this study was published in which they have changed from ECF to FLOT. What they have started is, they have started giving 5-fluorouracil, leucovorin, oxaliplatin, docetaxel versus ECF. So this FLOT trial was compared to the routine ECF usage in 716 patients, of which 360 were given ECF and 356 were given FLOT. And what they have compared at end of the study, what nearly 72 months follow-up, what they have found is the patients with FLOT regimen have better overall survival and better disease-free survival as compared to patient with ECF. And when you look into toxicity profile of this chemotherapy, nausea and vomiting was significantly more in FLOT regimen as compared to ECF. So what they have said is, if the patient is fit, clinically fit, or ECOG 1, a FLOT trial is better as compared to ECF in patients with carcinoma stomach. So these are the landmark papers which have changed our management in carcinoma stomach. We have moved on from a D1 gastrectomy to D2, and now we have moved on from adjuvant chemotherapy to neoadjuvant or a perioperative chemotherapy in carcinoma stomach. Thank you. That would be all from my side for upper GI.
Can we have the discussions on the topics? I request chairpersons to please initiate and find out if there are questions for the audience, because that will be better to answer.
Dr. Deshmukh has the questions from the audience. I think you have the admin login. So if you can share the questions from audience first, and then we can have discussion, I guess.
If there are any questions on comments by the chairpersons, they are welcome.
Saurabh.
Yes.
After POEM, the incidence of GERD is relatively more.
Right.
In spite of that, you said it's better. The results are better than the endoscopic surgery. What is the reason why POEM is considered better compared to the endoscopic surgery? Laparoscopic surgery.
Compared to pneumatic dilation, it is better.
No, it is better than pneumatic. That was another question, that if the results of pneumatic dilatation are not that good, should it be continued as a modality of treatment? And if yes, why?
See, I think the first thing is in terms of effectiveness, if you see both modalities, the surgery, that's laparoscopic Heller's myotomy with fundoplication, in the NEJM study, both the effective treatments for POEM beyond pneumatic dilation, right, are surgery or POEM. In both, the reflux was 30 to 40%, which is, I think, higher than what we all see in clinical practice in this study. Having said that, I agree that because we don't do fundoplication in POEM, the risk of reflux is higher in regular POEM than in laparoscopic Heller's myotomy. Probably in the real world data, it's about 10 to 20%. And I would imagine it must be lower than that for fundoplication. I'm not sure how much in your experience. That's one. For pneumatic dilation, I think the advantage is, although it's less effective, it's very easy. And patients, it's a quick procedure, and patients who have bad esophagus, severely sigmoid esophagus, elderly with comorbidities, it may be a good option for treatment for those patients for just improving quality of life. But yes, if compared to POEM, POEM is superior than pneumatic dilation for any regular achalasia coming through the door.
I think pneumatic dilation. Hello.
Yes.
I think pneumatic dilation is the most simple procedure that can be offered to the patient, and almost 50% of patients, the data says up to 70 to 80% of patients respond to pneumatic dilatation. Apart from those type 3 achalasia patients.
Right.
So it can be considered as the first line of treatment. If it fails, surgical as well as the POEM is always the option that is available to the patient.
Yeah, I think the issue with, I personally, again, this is not proven in data or studies. From what I've seen, patients, definitely a lot of them get better with pneumatic dilation, but then a lot of them with recurrence, when they come back after years, then you are in a really bad shape because their esophagus is all sigmoid. And by the time, if they can't undergo regular, say, POEM, or if that's a challenge, then they may even have to undergo esophagectomy. That is my only take on it, because I've seen patients who have come to us after 10 years of pneumatic dilation.
That can be improved with better follow-up, I think.
Potentially, but then a patient who's asymptomatic, say I had a patient who had 2008 pneumatic dilation, 2015 came back, had a sigmoid esophagus, but symptoms were not there, right? Yes, last week I did the POEM on the patient after 12 years of pneumatic dilation, severely sigmoid, very challenging. We got it done, but I'd say if the POEM was not an option, patient would have required sigmoidectomy. Regular Heller's myotomy may not have done the trick. I guess we have offered POEM, quick, simple, get it done. If not, then...
But what happens 12 years down the line of POEM, we do not know.
I agree. And I think we don't know. But what our guess is, with any of these effective myotomy procedures, say Heller's or POEM, with the way you cut the muscle and it's a very effective procedure. So we will see what happens. But my guess is the rate of sigmoid esophagus should be less with Heller's or POEM than pneumatic dilation. But again, that remains to be seen when we have long-term data.
But I think if you have a patient who is young and probably has to go many years, then I think you should offer them the best of the treatments which are available. I agree that
pneumatic versus, say the question is, there is no comparison between pneumatic dilation and POEM versus surgical treatment. The comparison is there between surgical versus POEM. So, given a choice, what is the choice?
You raise a point that whom to offer the balloon dilatation is better in 50% of the patient. That was also our experience. But if you are given a chance, I think younger patients should be offered a POEM more than the balloon dilatation.
As the primary treatment?
Huh?
As the primary treatment?
Yeah, as the primary treatment.
No, we actually in the West, they have moved to POEM as primary treatment.
So even I agree to that we should either operate or offer a POEM as a primary treatment, because when it comes as a secondary treatment, the esophagus is scarred. When we do surgery for post-dilatation patient, or if you are performing POEM on a post-dilatation patient, the difficulties are more as compared to a naive esophagus, which we see first time.
Right.
There is a lot of fibrosis. The chances of opening up the mucosa while we are doing surgical intervention in a post-dilatation patient are more as compared to the patient who has been operated first time. So why to land up with that issue and offer the best available treatment to that patient?
I would say that the balloon dilatation is also a myotomy, but it's a very haphazard myotomy. It's better to offer a endoscopic or surgical myotomy, which is more precise.
And I think pneumatic dilation certainly has its role. There are patients who say fail any of our myotomies. That it's an easy option as a backup. Patient has failed Heller's or failed POEM. It's not a bad idea to do pneumatic if it works. Why not? And also patients who are old, had bad esophagus, comorbidities. You don't want to subject them to general anesthesia, and just improve their quality of life. Absolutely use pneumatic dilation. It's not going anywhere. I think.
What we are discussing, I would like is the algorithmic approach to a patient. It has to be tailor-made. That is what it seems. So, in a given case, study is okay. In fact, in this study, interestingly, many patients who had a failed POEM went back to balloon dilatation. So, you see, it might work in a particular patient, and it depends on what kind of situation you are in. So, when it comes to treating a patient, I think we need to have an algorithmic approach. Simple, as Saurabh has said, regarding old patients and patients where it is a simple approach may be better than doing an intervention or surgery or even POEM for that matter.
Right. Yeah, I agree. And, I think we can use a combination of these depending on the mucosa, depending on the esophagus, depending on the comorbidities. I think the options can be individualized, which I agree.
Sir, regarding the refractory heartburn paper, I would like to say that before we say surgery is good for the refractory heartburn, we have to consider that the 80% people we have to explore by doing their extensive evaluation and then go for surgery.
Yeah. In fact, that was the reason why I presented that paper, that out of 100, I think they had a group of about 300 odd patients, out of which only 78 were randomized. Because many of them, they were not taking proper PPI on empty stomach. So around 10 to 15% who were not taking proper PPI were excluded because they got relief on taking PPI on empty stomach. Some of them turn out to be achalasia, some of them turn out to be cardiac disease, and majority of them, they were functional heartburn presenting as burning.
So that,
in fact,
means
so 20% of the patients who were referred as refractory heartburn were randomized. So that message is very well taken and should be emphasized that patients who are refractory, one should rule out eosinophilic esophagitis, drug-induced esophagitis, achalasia, malignancies, and so many other things, cardiac disease, and also see to it that the patients are taking PPI on empty stomach so that they are better in that.
Yeah, there is a question from Dr. Vinod Adbe. He says, why POEM has more reflux?
See, I think the issue with POEM is that although it's minimally invasive, it's relatively sort of benign procedure in that sense, but we do fundoplication. Patients can have more reflux or a laparoscopic myotomy, which undergoes fundoplication. But having said that, I think we are optimistic that there's some
Atish,
Can you
you're not
please
able
mute
to.
Dr. Atish Bansal, sir? Can you please mute Dr. Yeah.
Okay, sorry for that. So yeah, I think the issue is the fundoplication not being performed. Although the study, the randomized trial has shown much higher rates, which is more than what has been seen in clinical practice or in many centers. So I think the overall rate should be in the range of 10 to 20%, which is more than Heller's myotomy, no doubt. But a lot of these patients are actually asymptomatic from GERD. If you've seen any of these patients, they do have grade A or B esophagitis, but then they are really asymptomatic. And, that's happened in 2 of the patients that we had. Actually, none of them had reflux symptoms. They all were incidentally found on endoscopy on our, protocolized manner when we do endoscopies in these patients. So that's been our experience. But definitely the advantage is esophageal dysmotility patients, type 3 achalasia, because we can tailor it based on the patient's, the myotomy. We just did a 27 centimeter myotomy in a type 3 achalasia patient, which is, which you cannot do in any other modality. We treated a distal esophageal spasm with a 22 centimeter myotomy recently. So these are, it's the most effective way because you can go really high up in the proximal esophagus. And, these patients just stay for a day and then they get discharged generally.
There's a comment by Dr. Bhandarkar, sir. He said POEM is more effective and safer as compared to pneumatic. Then there's one more question by Dr. Sudesh from Usad. He has asked about surgical treatment for cardiospasm. So maybe Yogesh can take this.
So cardiospasm is basically what achalasia was before before we coined the term achalasia. Cardiospasm was the same. If you look into the literature of achalasia, it's all started with cardiospasm, and the treatment of cardiospasm is same as we do for achalasia.
Yeah, I think it's a synonymous term.
So I guess the most important thing which has happened in the management of achalasia or our understanding of achalasia is the types of achalasia which have come up on the manometry studies which we are getting now. So type 3 achalasia, which requires a long myotomy, which is surgically a bit difficult to make. That as Saurabh said, we made a nearly 27 centimeter myotomy. It's impossible practically to make that long myotomy surgically. So better understanding of achalasia, better understanding of those types, and then offering the patient the best possible option. If it's type 3, then surgical is definitely no. These patients go for POEM. That is a better option. If it's type 1 and type 2, then we can counsel the patient, tell them pros and cons of both, and then take up the patient accordingly, according to his wish.
Right. Okay. Should we move to the next?
Yeah.
Should be moving on to the next.
Are there any questions?
Yeah, one question to Mukhyavar sir regarding the urgent versus early endoscopy. So what's your take on that, sir? What's your experience about offering, especially when you take patients who are in shock, like they come with massive GI bleed, they get ventilated, they become oliguric, and they keep bleeding. So you think early endoscopy still has a role, urgent endoscopy, I mean, as compared to early endoscopy? Or you still think if you include patients with group of shock?
Urgent endoscopy would certainly have a role in those patients, those with portal hypertension. That's my take. Unless until you do the trials and find out, because this urgent endoscopy being intervention in the early hours before this thing leads to more mortality and more complications is sort of unheard. But when you randomize the patient and do a scientific study, you come out with some these new things. So unless until you study this particular aspect, but in this particular trial, they haven't taken patients, those who were in shock.
Sure.
So they didn't want to randomize them. Okay.
So it is
so these patients were less severe bleeding patients. So the message should not go that patients with bleeding, the endoscopy can be delayed.
It's a more gastroenterologist friendly OPI.
Our setup, our area, I would say that where portal hypertension is a dominant, it's one of the largest causes of bleed. More than 40 to 50% of patients with upper GI bleed are having portal hypertension. So this particular statement may not be applicable to our area. That is what I feel. But I can't answer that question whether it will be useful unless until we do the scientific study and compare.
So basically, the article would have said that there is no added advantage of doing an urgent endoscopy or an early, it is acceptable. But when it says that there is increased mortality with an urgent endoscopy, then definitely this is something which is new to us.
Actually, basically, they wanted to stabilize the patient first and then go ahead with it, you know.
Yes. Okay, so I think we should move on to the next session.
Other sessions with the permission of chair.
So we would like to start the next session on pancreaticobiliary. Once you have Dr. Mukhar sir, you would like to take.
Yeah.
Okay, we will just.
Well, there are many papers in this pancreatobiliary. Severe acute gallstone-induced pancreatitis. There was a trial without patients with cholangitis. They definitely require urgent ERCP. But those patients with severe acute gallstone pancreatitis, they were randomized to undergo urgent ERCP with sphincterotomy versus conservative treatment. This was again a multi-centric randomized trial, 26 centers in Netherlands. Most of these patients had severe acute pancreatitis as suggested by Apache score and the Bishop score. The primary endpoint were two: mortality and major complication, and the secondary endpoint was readmission. This trial was published in Lancet. 26 centers participated. With large number of patients in this group, 117 in urgent ERCP group, 113 in conservative treatment group, and both the groups were almost like matching with each other. Mortality with urgent ERCP was 38%, and conservative treatment was 44%. So the p-value was not significant. The mortality and major complications. The mortality was 7.9%. Again, p-value was not they were not significant. There was a higher incidence of cholangitis in conservative treatment group, 10% as compared to 2%, and the readmission for gallstone-induced complications was more in the conservative group than the urgent ERCP group. So basically, it's a negative trial. There is no benefit of urgent ERCP in predicted severe acute pancreatitis as compared to conservative treatment in terms of complications and mortality. Cholangitis was more in conservative group, but these do not include patients with cholangitis where there could be a role of early ERCP. Now, the second topic which I am going to discuss is post-ERCP pancreatitis. Most common complication of pancreatitis and most dreaded complication is post-ERCP pancreatitis. The incidence is as high as 15% in high-risk patient. Tremendous healthcare cost, $200 million in US. The rectal NSAIDs and pancreatic stenting are the two approved treatments. I am going to discuss with you three papers which are there in this. This paper, again from Hong Kong group, primary needle knife fistulotomy versus conventional cannulation method in high risk cohort of post-ERCP pancreatitis. So those patients who were high risk, as suggested by the young patients, females, obese, having SO dysfunction, normal bilirubin, normal bile ducts, but suspected biliary disease, having a previous acute pancreatitis. These were the inclusion criteria. So these, one or the more of the risk factors was there. So these, once you see the young female, obese, SOD, normal bilirubin, normal CBD, they are more dangerous to have the pancreatitis. And the groups were not matched certainly, but the malignant biliary disease was more common in the conventional group. SO dysfunction was 9 patients versus 3 patients in needle knife group. But then the other characteristic, the groups were matched. Post-ARCP pancreatitis was defined as abdominal pain with elevation of amylase and lipase more than 3 times post-procedure. 14.1% was the incidence in high-risk group with the conventional method as compared to 0 incidence with the needle knife. The cannulation success was 97% with needle knife as compared to 89% with conventional method. Explanation for decreased risk of pancreatitis with needle knife, that you start incision 2 millimeters away from the pancreatic duct. You don't inject contrast. There is no catheter, hence no pulmonary pancreatic duct edema, no thermal injury. The limitations of these patients, the trial was small number of patients with SO dysfunction. Prophylactic NSAIDs were not used in this trial. Pancreatic stenting was at the endoscopic discretion. PD stent were more in CCM group. So on the other hand, the needle knife group did not have a PD stent, but still having matched the SOD and malignancies, the incidence of pancreatitis was more in conventional group than needle knife group. So summarizing, I would say that this may be a game changer, that those patients, those experienced endoscopies, those who have done more than 300 ERCPs and more than 20 needle knife were there in this group. At the experienced hand, the primary needle knife fistulectomy decreases the risk of acute biliary pancreatitis, than the conventional method. The second trial is a randomized trial of topical epinephrine and rectal indomethacin for preventing post-ERCP pancreatitis in high-risk group. This was from 4 centers, the centers from AIG, then Gleneagle, PGI Chandigarh, and the John Hopkins. So these were the 35 different drugs being evaluated to prevent post-ARCP pancreatitis with inclusive results. Rectal NSAIDs were most effective as suggested by Ilmenzer 2012. Pancreatic stent placement and rectal NIC, these are the 2 most important modalities to prevent post-ERCP pancreatitis. In this study, they have decided not to put pancreatic stent, and the inclusion criteria were again 1 major and 2 minor: difficult cannulation, failed cannulation, pre-cut, pancreatic sphincterotomy, pneumatic dilatation, SOD, and earlier history of post-ERCP pancreatitis. In the minor criteria were young females and more than 2 pancreatic injections, pancreatic SNRization, or a breast cytology. So basically, high risk of patients with high risk of pancreatitis were taken, and they were randomized in 2 groups: indomethacin alone with normal saline spray and indomethacin suppository together with epinephrine spray. The 0.2 ml of epinephrine, 0.2 ml strength of 20 ml of epinephrine was sprayed over a period of 1 minute on the papilla. This you can see the effect of spraying of epinephrine. A is before epinephrine, B is after epinephrine. So what are the results? These are the risk factors: SO dysfunction, pneumatic dilatation, pancreatic cytology. They said that brush cytology. The post-ERCP pancreatitis was 10.2%. Odds ratio was 2, and there was no difference in the incidence of pancreatitis between indomethacin and combination group. So this indomethacin, epinephrine added to indomethacin, did not do any benefit, and this was possibly a negative study. Now, why the indomethacin epinephrine was used? Because in the earlier observation studies, they had seen the benefit, and they wanted to do it on the large trials. The mechanism by which it causes is, it causes arterial vasoconstriction, reduces edema, and decreases the pancreatic duct outflow obstruction. It is acting similar to that of PD stent, but for a short time. So this is no difference in incidence of pancreatitis, a negative study. Then combination of diclofenac and sublingual nitrate is superior to diclofenac alone in preventing pancreatitis after ERCP. This was published in Gastroenterology 2019, study from Japan. And nitrates are the smooth muscle relaxants. So relaxes papilla and increases pancreatic blood supply by 56%. NO produce dilatation. The nitrates produce NO, which causes dilatation of microcirculation and thereby causing the benefit to the pancreas. So diclofenac 50 milligram was used within 15 minutes of ERCP, and the isosorbide was given 5 milligram 5 minutes before ERCP sublingually. And there were significant number of patients in this Japanese trial, 444 and 442. They were all matched. Most of them, they were matched. And the p-value you can see here, almost matching p-value. Post-ERCP pancreatitis was 5.6% in the combination group as compared to 9.5%. And the severe pancreatitis was not there. Mild to moderate pancreatitis again was lower in the combination group as compared to diclofenac alone. Hypotension occurred in a couple of patients in 35, 7.9% in combination as compared to 2%. So hypotension was more because of nitrates in the... So the combination of sublingual nitrates and diclofenac better in preventing post-ERCP pancreatitis. Benefit is both groups with or without risk factors. Earlier studies we have seen with high risk of pancreatitis, large number of patients. The dose of diclofenac was used 50 milligram than 100 milligram. Probably their explanation is that the Japanese are low weight, so they have used low dose. But of course, there's no double-blind setting. Sublingual nitrates, lack of double-blind setting. Ulinastatin was given to all, and statistically, it has not come as significant, but numerically, it has shown benefit. After post-ERCP pancreatitis, I will go on to the malignant hilar biliary obstruction. This study, which is published in GI Endoscopy 2020, optimum stent placement strategy for malignant hilar biliary obstruction, a multicenter parallel study, mainly from China. So endoscopic stent placement is the mainstay palliative treatment, and majority of these patients are unfit for surgery. Hilar stenting is challenging, multidisciplinary approach. It requires hepatobiliary team. The controversy exists whether we should put a plastic stent or metal stent, whether to drain unilateral or bilateral. But whatever is our knowledge, it is understood that 50% of the volume of liver needs to be drained for better results. So 1239 patients with advanced biliary obstruction, mainly type 3 and type 4, endoscopic stent placed in 4 centers, 633 classified in 4 groups, bilateral metal, unilateral metal, bilateral plastic, unilateral plastic. So as you can see here, this is a malignant hilar obstruction, unilateral metal going into the right system, then unilateral plastic, again right system, bilateral metal in both system, and bilateral plastic. So if you see the matched controls, Bismuth type 2 patients were less than 10% in most of the group, but type 3 and type 4 patients, especially type 4 patients, more than 80% of patients were type 4. So in advanced biliary malignancies type 4, where there is always a question whether to do PTBD or ERCP. So these are the results. Clinical success of the number of patients in bilateral metal 87, unilateral metal 97, bilateral plastic 91 and 81. So significant number of patients. Clinical success was more in bilateral than unilateral metal as well as plastic. Cholangitis was less. Stent patency was almost, if you compare to plastic, it was 9.6 months, and the mean interventions were low. So this is to tell you the clinical success. You can see the brown bar on the left-hand side. The more clinical success, less cholangitis, less time for intervention, so less severe cholangitis, more stent patency, and more overall survival, almost like twice more survival. So conclusion, metal stent placement associated with better jaundice control, lower post-ERCP cholangitis and intervention, longer stent patency, and probably this is the first trial which has shown that there is an improved overall survival with the metal stent. There are 3 reasons. One, the stents are large diameter, migration is less because of better flexibility and stability, and the reticular structure allows drainage of the branch bile ducts. Bilateral is better in control of jaundice, prolonged stent patency, longer survival. So bilateral metal stent placement should be the first choice if possible. Unilateral metal stent has advantage over plastic in terms of cholangitis, oral survival, higher clinical success, and longer patency. So given a chance, even in class Bismuth type 3 and 4, bilateral metal stenting is the procedure of choice. Then plastic stent. Metal stent should be preferred over plastic stent. So with this, I finish my presentation and hand it over to Saurabh for.
Okay, just to continue in the theme of pancreatobiliary, just to discuss acute cholecystitis, lap cholecystectomy is the gold standard treatment of choice for acute cholecystitis. For patients unstable for surgery, PTGBD, which is percutaneous gallbladder drain placement, is performed, followed by delayed lap chole when condition improves. But for patients who remain high risk for surgery due to, say, age or comorbidities, long-term management strategy is not defined. So just to illustrate what we'll talk about today, PT-GBD is a percutaneous placement of a drain in the gallbladder, and EUS-GBD, which is endoscopically guided, endosonographically guided gallbladder drainage using metal stents. So just to illustrate for people who are not aware of this modality, this is a patient which we just did, elderly male with advanced hilar cholangiocarcinoma, status post bilateral stents, presented a few months later with acute cholecystitis. So this was not somebody who wanted to undergo surgery. And then we ended up performing endosonographically guided stent placement in the gallbladder for treatment of cholecystitis. So this is EUS guided, as you saw. The stent catheter is advanced under EUS guidance, and a metal stent is deployed across the gastric or sometimes the duodenal wall, and with drainage of contents. All right. So this takes you to the recent study, which is published in Gut, endosonography guided gallbladder drainage versus percutaneous cholecystostomy in very high-risk surgical patients with acute cholecystitis. It was an international randomized multi-center controlled superiority trial. So the prospective multi-centered open-label randomized controlled trial, including 5 high-volume institutions. They included adults with grade 2 and 3 acute calculus cholecystitis, but were considered very high risk for cholecystectomy. These were patients, say, over 80 years of age, or ASA grade 3 or above, Charlson's comorbidity index of greater than 5, or Karnofsky score less than 5. So basically patients who are, had multiple comorbidities or elderly patients. 665 patients were screened, and 545 were considered operable candidates and therefore were excluded. And then 40 were additionally excluded for various reasons like patient refusal, etc. 80 were randomized to undergo EUS-guided gallbladder drainage versus percutaneous cholecystostomy. Only 1 was excluded for gallbladder cancer. And just to briefly compare the 2 groups, they were basically similar with regards to their comorbidities. Outcomes, technical success was similar, just 1 failure in the EUS gallbladder drainage group because they could not identify an avascular path across the stomach or duodenum. Clinical success similar between the 2 groups. Pain scores were less with EUS guided gallbladder drain because it's internal and patients don't experience any percutaneous drainage. 30-day and 1-year adverse events in both the groups were different. 30-day adverse events were significantly lower in EUS guided gallbladder drainage group, 12.8% versus 47.5%. And 1-year adverse events were significantly lower, 25% versus 77.5%. And recurrent acute cholecystitis, which was a problem in the PT-GBD group, was not seen in the EUS group because they used metal stents and these were eventually replaced. So that's the difference in terms of adverse events. And tube dislodgement, which can be a nuisance with PT-GBD because these patients say did not underwent cholecystectomy. So the tube was a problem and the tube would get dislodged or get blocked and then would require frequent exchanges. So if you see, reinterventions were significantly more into PT-GBD group 12 versus 1. Unplanned admissions were significantly more, 50% versus 15%. And overall adverse events, as I mentioned earlier, was more in the PT-GBD group. So the discussion and conclusion, endosonography guided gallbladder drainage and percutaneous gallbladder drainage are both safe and effective methods for draining the gallbladder in patients suffering from acute cholecystitis. EUS-GBD has reduced adverse events, reduced rate of recurrent acute cholecystitis, reinterventions, and unplanned admissions. Patients which remain high-risk candidates of surgery, overall EUS-GBD should be considered over PT-GBD, primarily because once the drain is in there and a patient is not going to undergo surgery, then the percutaneous drain can be a nuisance to manage in the long run. And if you cap it or remove it, then patients are at risk of recurrent cholecystitis. For patients who are operable candidates, EUS can pose challenges during surgery. There's no data. There's 1 study which has shown that it's possible and done successfully, but it can be a bit of a problem compared to a percutaneous drainage. So there's no data on surgical outcomes after EUS-GBD. It should be, the problem is that it's only performed by specialists and expertise is not widely available. All right, so I will move on to walled-off pancreatic necrosis. I will request Yogesh to chip in because he will be going through the introduction part a little bit. Just to say, acute pancreatitis is complicated with necrosis in 20% of the cases. Necrotizing pancreatitis is associated with very high rates of mortality and complications. Minimally invasive approaches have replaced open necrosectomy as a standard of care. And I'll let Yogesh unmute and sort of go through the next few slides. Yeah, Yogesh, you can let me know and I'll move to the next slide.
So if you can look at your slides there, what Saurabh is sharing, this is what we have worked up together. So these are the landmark papers which we are discussing. So how we have evolved in management of necrosectomy, that is what I am going to tell you today. So there was an era where we always used to do open necrosectomy, and the necrosectomy was done usually in the second or third week when the patient landed up with infection or infectious complications. So there was an era of open necrosectomy and an early open necrosectomy before 1997. So we evolved from early and we went on to delayed necrosectomy, that is from less than 4 weeks. We waited up to 4 weeks and then we started doing necrosectomies. From open necrosectomies, we evolved to minimal invasive necrosectomies. And from minimal invasive, now we have gone up to a stage where we are doing endoscopic necrosectomies also. So how this evolution has happened, I'll tell you one by one. Saurabh, next. So if you look into timeline of systemic inflammatory response in acute pancreatitis, the first graph, if you can see, as soon as the patient presents, the SIRS is at peak. By our conservative treatment of fluid management, over a period of 2 weeks, the SIRS goes down. In nearly 20 to 30% of necrotic pancreatitis, infection sets in after second or third week, after which the SIRS goes up again. So at this point, we give antibiotics and we plan some intervention for that infected pancreatic necrosis. What intervention has to be planned? It could be a percutaneous, endoscopic, laparoscopic, walled, or it could be an open necrosectomy. So that is how a acute pancreatitis patient goes off. First 2 weeks, it's conservatively treated, and after once the infection sets in, the systemic inflammatory response again goes up, and then that has to be managed with antibiotic or intervention. Now, how to blunt this intervention, how to blunt this SIRS response by doing a good intervention is the thing which we are going to look into. Saurabh, next. So if you are doing an open necrosectomy, the SIRS response to your surgery will also add up to the infection which is there in the patient. So if you want to blunt the response, you have to go with least invasive approach. That least invasive approach could be just placement of a percutaneous drain. It could be just an endoscopic drain placement into the stomach, into the walled-off necrosis through the stomach. So your aim when managing an infected pancreatic necrosis is to blunt the systemic inflammatory response syndrome. As you blunt that response syndrome, the chances of good recovery, the chances of less morbidity and less mortality are more. So if you want to decrease your mortality and morbidity, you need to decrease the blunt, you need to decrease or blunt the systemic inflammatory response, which you get at this point when you are intervening. So what are the interventions we do? Saurabh. This was the first journal, as I said, it was published in American Journal of Surgery, February 1997. This group studied early versus late necrosectomy in severe necrotizing pancreatitis. And what they found in early group, if you do surgery early, the mortality is nearly 56%. And as you delay the necrosectomy by more than 4 weeks or 5 weeks, the mortality comes down to nearly 27%. Even today, with all the available gadgetries or all the advancement we have in infected pancreatic necrosis, the mortality still stands to 15 to 20% in infected pancreatic necrosis. So this was the first article, landmark article. We changed our concept in management of infected pancreatic necrosis. We changed our concept from early necrosectomy to delayed after February 1997. Next. Then came this Panther trial. This was actually in NEGM. It was in 2010, in which a step-up approach or open necrosectomy was compared in 2 groups. Step-up approach included placement of a percutaneous drain, followed by minimal invasive or retroperitoneal video-assisted retroperitoneal drainage or video-assisted retroperitoneal necrosectomy. Step-up approach versus an open necrosectomy. 88 patients were randomized and 45 were included in open necrosectomy group and 43 were included in the step-up approach group. Next. So what their results were? The results were if you do minimal invasive or a step-up approach, the new onset organ failure or multiple organ failure are far less, statistically significant less as compared to primary open necrosectomy. Same thing, if you are doing open necrosectomy, then chances of developing incisional hernia, new onset diabetes, or requirement of pancreatic enzymes in these group of patients were significantly higher. So this was one of the article which made us think our open necrosectomy, and we shifted ourselves from open necrosectomy to minimal invasive approaches. That is placement of a percutaneous drain first, removing all the infected liquid material. Many of the patients settle with that. Nearly 40 to 50% of the patients settle only with drainage. If they don't settle up, then through that track, we go in and we do retroperitoneal drainage, video assisted retroperitoneal drainage. Why? The onset of organ failure or the chances of having incisional hernia, diabetes are far less in step-up approach. So this Panther trial made us evolve from open necrosectomy to the minimal invasive approach. Next. Then came this randomized trial in 2012, endoscopic transgastric versus surgical necrosectomy for infected pancreatic necrosis. What they specifically studied was the level of interleukin 6 in surgery versus transgastric endoscopy group. In this trial, they wanted to show that surgery induces more inflammatory markers. They wanted to present that least invasive technique, that is endoscopic transgastric drainage, is better as compared to surgical necrosectomy, and that they have proved here. As you can see, the blue marker which shows the interleukin 6 level after surgery are significantly more as compared to the interleukin 6 level in endoscopic group. So in this 10 patients were analyzed in each group, and what they have found in results is next, Saurabh. What they have found is the major complications are far less in endoscopic group as compared to surgical necrosectomy group. Now in this trial, only issue was surgical necrosectomy was also open. They were not exclusively minimal invasive surgery. The minimal invasive versus endoscopic was not compared. It was a surgical necrosectomy per se, open necrosectomy. That's why you can see that difference between the both the groups, that major complications are more in surgical necrosectomy group and pancreatic fistula are more as compared to endoscopic transgastric necrosectomy. So this is how the evolution, we moved on from minimal invasive necrosectomy to the least invasive form, that is endoscopic transgastric necrosectomy. The next paper will be shown by Saurabh on that transgastric necrosectomy.
Okay, thank you. Thank you, Yogesh. So just as we're discussing endoscopic transgastric necrosectomy, I just wanted to just briefly show what it is for people who are not very familiar with this. On the left side here is the endosonographic view from across the stomach wall of the necrotic cavity, which is all dark in appearance. And what we basically do is ensure there are no blood vessels, and then we get access across the gastric wall. And then we eventually deploy a metal stent, which is what we prefer now in most of the patients. As you see here, right, in the proximal part of the stomach, it's being deployed. And as you'll see in a few seconds, there's a large amount of pus that has come out in this patient. So that's really the method for endosonographically guided placement of the stents. Not all, but some of these patients require necrosectomy. And just to show how it looks like, this is a patient who is getting sessions of necrosectomy. We go across the stomach through the stent, and you see here this pus, and using various tools, we manually debride the cavity and remove all the necrosum. So this is required in a few of our patients, and that's just basically to highlight what it is. All right, so moving forward, that was the preliminary study which Yogesh showed. Of course, a very small study, few patients with difference between endoscopy and surgery. So the authors followed up with a much larger trial. This is the Dutch pancreatitis group, which is published in Lancet in 2018, comparing endoscopic versus surgical step-up approach for infected necrotizing pancreatitis. I just want you to be aware, as we discuss, their endoscopic approach consisted of a transgastric placement of plastic stents and not metal stents, which is what we use now. No problem. So the study design was a multi-center randomized superiority trial. Superiority, which means they're trying to say that endoscopy is superior to the surgical approach based on their prior evaluation. And that's what they were trying to test in this study. Patients with confirmed or suspected infected pancreatic necrosis were enrolled. Just to show the flowchart, 418 patients were evaluated. 158 did not have infections, so they were not considered. Out of the 260, only 162 were excluded because either they did not meet the inclusion criteria where they could not do surgical or endoscopic step up, or majority of them probably because of tertiary centers had undergone prior invasion before they presented. So only 98 were randomly assigned, 51 in the endoscopy group, 47 in the surgical step up approach group. The primary endpoint, as you see in these trials, is a composite of major complications or death. The major complications, which most of these trials have sort of used, is new onset organ failure, cardiovascular, pulmonary, or renal, bleeding, which requires intervention, perforation of a visceral organ requiring intervention, enterocutaneous fistulas, or incisional hernia. So just to highlight, baseline characteristics were not very different between the two groups. Comparing the results, there was no difference in this trial in terms of major complications or death between the two minimally invasive approaches. But if you see, the cardiac failure or persistent cardiovascular failure was more in the surgical step-up approach group compared to endoscopy step-up group. Pancreatic fistula, as you would expect, was much more in the surgical step-up approach versus endoscopy. Just the reason for the pancreatic fistula in this group was some patients required percutaneous drainage additionally for extension in the paracolic gutters, and that's probably why some of them developed fistula. And the median number of interventions, the drainage procedures was less in the endoscopy group. Necrosectomies was more in the endoscopy group, as you see here. But if you see, 43% did not require any necrosectomy, despite putting plastic stents in. 1 or 2 sessions were required, and most of them, and quarter of them, required more than 3 sessions. And the days of in the hospital were significantly less in the endoscopy group versus the surgery group. So I will move on to another trial just before we conclude with the findings, because it's another similar study published in Gastroenterology, which was again comparing endoscopic transluminal approach compared with minimally invasive surgery. The difference is this: in this particular study, they did include those undergoing endoscopic placement with the lumen opposing metal stents in almost half the patients, which are superior to the plastic stents, as we have understood over time now. So hence, probably better results in this study, as you will see. This was a single center randomized controlled trial. Adults with confirmed or suspected infected pancreatic or peripancreatic necrosis were included. And just move forward. Baseline characteristics were not different between the two groups. And again, going back to the results of the study, in this particular study, the primary composite endpoint, which I had outlined in the earlier study of major complications or death, was much lower in the endoscopy arm, 12% versus 40% in the surgical arm. And the secondary endpoints, which is the duration of procedure, was shorter in the endoscopy arm. And the post-procedure SIRS was significantly lower in the endoscopy arm, which is sort of the pathophysiologic basis for an endoscopic approach as outlined by Yogesh in the prior study. And this is just a graph to highlight the SIRS overall was less in the endoscopic arm. And the other findings, necrosectomy was performed frequently once. I think it's more in the surgery arm, probably because they use metal stents here. So the necrosectomy overall requirement was lower, and length of ICU stay was also lower in the endoscopy arm. Number of readmissions were also almost lower in the endoscopy arm. So overall conclusion and discussion for management of infected pancreatic necrosis, overall what we feel now is minimally invasive approach is superior to open necrosectomy, which I think has been proven time and again by now. There's a trend towards suggestion that endoscopic approach is perhaps superior to the minimally invasive surgical approach, although not a major difference, but some of the recent studies seems to show that. The superior outcome in the gastro study, which I just showed you, was probably because of use of metal stents in 50% of cases, rather than the plastic stents used before. And the endoscopic approach is associated overall less SIRS, less fistulas, and less hospital stay. But there's really no difference in mortality between endoscopy and minimally invasive surgery. So AGA recommendations, putting this all together, just published last year, I guess slightly leaning towards the endoscopy, have suggested this algorithm. If you have a patient with walled-off pancreatic necrosis, and if patients have symptoms or if it's infected, if there's a central component just across the gastric wall, then endosonography guided lamps, metal stent placement, that is the preferred option. If not, then if it's away from the gastric wall and it's in the paracolic gutters, then percutaneous drainage is suggested. And if there's a large amount of solid debris, direct endoscopic necrosectomy is required. If not, then you remove the lumen-opposing metal stents after resolution, basically. And just to another algorithm as shared by Yogesh, if Yogesh wants to go across, essentially saying the same thing, which is, I mean, Yogesh, if you want to just go through this.
So it's all dependent on the type of expertise which you have and the location where your necrosis is. That is what this approach says. So if you have infected pancreatic necrosis and if you have a transgastric window, best is to place an endoscopic transluminal drainage first. If there is no improvement in 72 hours and there is a thick material, then you have to do transluminal necrosectomy, which is what we have been doing. And if there is a fluid, then just keep on aspirating that and redrainage. If there is no improvement even after doing all these things, then these patients may go for open surgical necrosectomy. If there is no transgastric window, then look for the access to percutaneous drain. You put a percutaneous drain, there is improvement, observe. If there is no improvement, and if it's a posteriorly placed, then video assisted retroperitoneal drainage. If it is anteriorly placed, like sometimes you have it is in the right paracolic gutter where going through ward is a bit difficult, that time percutaneous transperitoneal minimal invasive necrosectomy is also advised. So try to do it with least invasive methods. That is what is the crux of matter. Nowadays, open surgical necrosectomies should be avoided as much as possible. And in anywhere, if the patient lands up with bleeding complication, then transarterial embolization is the treatment for those patients.
Right. Yes. Thank you, Yogesh. I think it's always a team-based approach, and it should be individualized in each patient. All right. So just to wrap up this pancreatic issue, for those who manage these patients a lot more, what we understand is disconnected pancreatic duct syndrome, which means basically both the pancreatic ducts are completely disconnected after necrosis, and what really happens in these patients. And this is a study out of the Asian Institute of Gastroenterology in Hyderabad and published in Gut this year, where basically they move to US guided placement of metal stents. As we see here, they use US guided placement of metal stents for symptomatic walled-off necrosis. MRCP was performed 4 to 8 weeks later, followed by ERCP to confirm PD anatomy. If there's normal pancreatic duct, no pancreatic duct stent is placed. If there's pancreatic duct leak, they placed a PD stent. But if the PD is completely cut off, that means it's called disconnected pancreatic duct syndrome. They decided not to put any PD stent or do pancreatic sphincterotomy, and then they removed the metal stent in all of these patients regardless. So overall, if you see, just to highlight the PD anatomy, when patients underwent ERCP in these patients, normal PD was seen in 14.4%. Majority of them had disconnected pancreatic duct, 73.8%. Some of them had PD stricture, leak, and calculi. So, and the location of disconnected pancreatic duct was almost divided, with almost half the patients in the head genu region and half of the patients in the body and tail region. So the results, they said recurrent pancreatic fluid collections developed in a very small proportion of patients, 13% in this study. Majority of these cases who developed recurrent pancreatic collections had disconnected pancreatic duct. The risk of recurrent collection was significantly higher in these patients with disconnected duct versus not having that finding. Reinterventions were required in only half of these patients who were symptomatic recurrences. So And also the next thing they found was 27% developed new onset diabetes, and disconnected pancreatic duct patients had more risk of diabetes than who did not have disconnected pancreatic duct. Proximal DPD, that's in the head genu region, had more problems than the distal pancreatic duct if there was a disconnected duct syndrome. So bottom line, low risk of recurrence in pancreatic fluid corrections following removal of lamps. So practice has been to remove the metal stents and replace them with double pigtail plastic stents. Perhaps not needed. And also it's a little difficult to place because they just come out. So this is probably not needed because of a very low rate of recurrence of pancreatic collections. New onset diabetes associated with disconnected pancreatic duct, likely because the segment of pancreas proximally, which is remaining, basically atrophies, and therefore patients can get diabetes. As they found that patients who had a more proximal disconnection, where a large segment of pancreas parenchyma was completely devoid of a connection with the intestine, eventually atrophied, and therefore high risk of diabetes in this patient population. All right. Okay, we'll move forward from this.
I'll just
fast.
I'll just
It's already late.
I know. This is one paper, but this is an observation study published very recently in endoscopy. It's not GI endoscopy, it's endoscopy 2021 January. All these patients with type 3 hilar block were taken. ERCP endoscopic procedures were compared with PTBD, group A and B. I'll just tell you the results. Number of patients in both the groups are 19 and 17. But recurrent biliary obstruction, as you can see, was in only 26% as compared to 88% in PTBD group. And the time to the obstruction was 92 days in endoscopy group as compared to 40 days in PTBD group. And the complications were also less. So the conclusion was ERCP and US combined provided significantly lower rates of biliary obstruction than PTBD. Complications and mortality were similar, though numerically they were less. It's a prospective observation study. Retrospective controls were taken. So this is not a very classically scientific study, I would say, as we discussed earlier studies. So, but why endoscopic better? Because large diameter of drainage tube, avoid external drainage which you get in PTBD. ER should be the first choice because, and then followed by USBD, because ERCP, the stent goes through the natural orifice. I think we can have discussion on this topic, and I'm afraid whether we'll be able to.
Chronic pancreatitis. I'll just
finish.
Sorry. Pancreatitis.
Yogesh has to do chronic pancreatitis. Yogesh,
I'll just finish off chronic pancreatitis. So I'm going to present a few papers of chronic pancreatitis. I'll do it as soon as possible, and then we'll have discussion. So yeah, can you see my screen now?
Yes, Yogesh.
Yeah. So chronic pancreatitis, as we all know, is also one of the very common diseases which we see in our area. And I am going to share 2-3 papers on chronic pancreatitis, which have compared basically endotherapy versus surgical therapy for chronic pancreatitis. So 2003, this paper which came up, this was the first randomized control trial which actually discussed endoscopic versus surgical therapy for chronic pancreatitis. So it was actually a group of 140 people, 140 patients who were selected for this study. They were explained in detail about both endotherapy and surgery, and they were asked whether they want to get enrolled in the study. And 72 of those patients agreed to get randomized. So out of 72, 36 went into endotherapy group and 36 went into surgery group. Now, one of the problem with this study was, in this study, only endoscopic stenting and stone removal was done. There was no availability of ESWL, or ESWL was not done in this study. So they actually did endoscopic stenting, they dilated the stricture, and if stone removal was possible, they did that. Comparative was comparison was between the stenting and surgery only. What you see is at end of 5 years, surgery versus endoscopy. This is the endoscopic group. Partial or complete absence of pain. At 1 year, it was nearly same in surgery as well as endotherapy group. But as you come up to 5 years, surgery group fared far better as compared to the endotherapy group. So a complete absence of pain at 5 years was nearly in 38%, 37% of patients in surgical group as compared to only 14% in endoscopic group. And nearly 35% of patients in endoscopic group had pain or there was no success in endotherapy. So this was one trial which first placed surgery far above endotherapy in comparison to management of chronic pancreatitis. But as I said, ESWL in which the stones are pulverized and that stone can be removed was not done in this study. That was the biggest criticism for this study. So this is the second one which came up later. This was by Kahan et al. And it was published in Gastroenterology 2011. So 39 patients underwent randomization, 19 in endoscopic group and 20 in surgical drainage group. In this, they underwent 16 patients underwent lithotripsy ESWL, after which stenting and ductal clearance was done. So 3 patients died. 1 had a duodenal ulcer perforation, rest 2 other non-related to CP. 16 completed follow-up in this arm and 15 completed follow-up in surgical arm. Again, study, a nicely done study, but number of patients were very less. When you look into the patients, 19 who underwent endoscopy, 4 patients initial treatment was failed, 3 had converted to surgery over a period of time. So nearly 50% of the patients needed surgery over a period of follow-up in endoscopic group. And in surgical group, 18% did not require any other treatment after surgery. Nearly 95% didn't require any other treatment than surgery. So comparative of pain is the thing which we look after in any patient or any study of chronic pancreatitis. What they have seen is complete and partial pain relief was seen in nearly 80% of the patients of chronic pancreatitis patients who underwent surgery, as compared to hardly 25 to 30% of patients of endotherapy. That was a statistically significant difference which they have seen here. And what they have said is in long-term symptomatic patients with advanced chronic pancreatitis who had underwent surgery as initial treatment had more pain relief from pain with fewer procedures than patients who were treated endoscopically. What they said was almost half of the patients who were treated with endoscopy eventually underwent surgery. They needed surgery. So this is what Kahan et al. Presented after ESWL, what response these patients get. So surgery was far better as compared to endotherapy. But the take-home message, what we have to look after in these studies is in this last thing which I'll be showing you. This is the Dutch pancreatitis group who has come up with early surgery versus endoscopic first approach in pain, management of pain in chronic pancreatitis. This ESCAPE randomized clinical trial published in JAMA in January 2020. So they randomized 88 patients, 44 received early surgical treatment. Early surgical treatment means as soon as the medical therapy in form of painkillers didn't work, patients were given surgical therapy in form of lateral pancreaticojejunostomy or phrase head coring. 44 underwent endoscopy in which some patients needed ESWL and some went directly for endotherapy in form of stenting. Both the groups were comparable in most of the aspects, as you can see here. What results shown was the Izbiki pain score, which is used to determine the pain intensity in patients with chronic pancreatitis. In early surgery, the Izbiki pain score were clinically and statistically less as compared to endoscopy first approach. And overall quality of life was better in patients who underwent early surgery. Even the interventions required, more the number of interventions were required in ESWL or endoscopy group as compared to early surgery group. As you can see here, this is the endoscopy first approach and this is the surgery, in which the overall pain scores, if you look after, has gone significantly less in early surgery group as compared to the endotherapy group. And the patients who had complete pain relief or partial or complete pain relief were nearly around 60% in surgery group as compared to endotherapy group, in which nearly 25 to 30% of the patients had pain relief. So what exactly we do in surgery is not only removal of stones. Like in endotherapy, you pulverize the stone and remove the stone. What we do in surgery is not only removal of stone, we even remove the inflammatory head mass or inflammation in the head. That is the head coring, which we do, and that gives a better result as compared to endotherapy. And the drainage which we attain, this is a complete head to tail drainage which we attain, that gives a better result in surgical group as compared to endotherapy. That is why surgery has a better chance of giving good pain relief. But the other thing which I want to stress here is, if you look into all these three studies, nearly 30 to 40% of the patients, they did respond to endotherapy. They did respond. So if we look into that, we might say that 40% of the patients may never need any surgical treatment if the endotherapy works for them. So this means that we should not say that surgery is the only treatment or the best form of treatment and all the patients should be offered surgery. It should be again tailored approach. If you have a pancreas which is filled of stone from head to tail, then that pancreas is never going to get cleared off with endotherapy. It's better if you offer surgery for these patients. If you have a patient with a huge head mass of 3 to 4 centimeter and then a dilated duct, even endotherapy for these patients is not going to work much. So these selected group of patients should be given early surgery, and rest of the patients in whom there is an isolated single stone in the head, which can be pulverized with ESWL or laser lithotripsy, these patients should be given a trial of endotherapy. Thank you. Yeah, another one from biliary. I'll just finish up this, just only 4 slides. So this is something which has come up in our surgical side recently. More and more usage of ICG or fluorescent based cholangiography. What they have projected is fluorescent cholangiography significantly improves patient outcomes for laparoscopic cholecystectomy. So this was actually a retrospective review of prospectively maintained database, and they performed to identify patients undergoing cholecystectomy at 2 hospitals. What they found was, in the patients in whom ICG was routinely used, the overall operative time, the overall conversion to open, drain placement, overall morbidity was as compared to the non-ICG group. So when they compared ICG versus non-ICG, what they found was overall operative time, overall conversion to open, requirement of drain, overall morbidity in ICG group was less as compared to non-ICG group. Why this has happened? Because with ICG visualization of CBD, you are far more comfortable in going up to the calots and clipping the duct. If the CBD is not visualized, like in this, you can see the operative time in BMI more than 30. The operative time in ICG was only 75 minutes as compared to 104 minutes. So if the BMI is more the fat covering that CBD, going up to CBD in inflamed gallbladder also, it becomes more difficult. So if you have a ICG and if you are using that in your camera system, then the comfort level with which you work around CBD or near the calots is far better. The same thing can be seen in inflamed gallbladder. As you can see, in inflamed gallbladder, the operative time was very less as compared to the non-ICG people. As same thing, the conversion to open was less, drain placement were less. Non-inflamed gallbladder, same findings were seen. So they concluded that over a period of time, as the technology has evolved, usage of fluorescent guided imaging for cholecystectomy will improve the outcomes. So ICG cholangiography is a non-invasive adjunct to lap cholecystectomy, leading to improved patient outcomes with respect to operative times, decreased conversion to open, and shorter length of hospitalization. Fluorescence cholangiography improves visualization of anatomy, thereby decreasing rate of CBD injury, Strasbourg type A injury, or mortality. These findings support ICG as standard of care during laparoscopic cholecystectomy. Thank you.
I think we can take the questions, and we will not be discussing further because there is no time. We already exceeded 2 hours.
Okay, sir, in the first trial that you, about the needle knife trial, needle knife is, prevents complication.
Yeah.
Do you agree with that inference conclusion?
What happens is actually if you are doing ERCP, most of the times needle knife is being used as a rescue procedure. But if you are used to doing hundreds of needle knife, then what happens is you switch on to needle knife early. As in my practice, if 3 or 4 cannulations, within 3 to 4 cannulations, if I don't get into the desired duct, I would switch to early needle knife. So if you have confidence in needle knife, it's always the same.
Because literature suggests the other way. Secondly, um, literature suggests that needle knife is associated with more bleeding, more pancreatitis, more perforations, while they are saying the other way around.
They are saying what you say is correct, but then these patients they started from 2 millimeter away from the papilla, and these were the experienced endoscopists who had experience of more than 300 ERCP and more than 20 needle knives. So I mean, they were not that senior experience, but in spite of that, what happens is majority of the times needle knife as a primary procedure, we haven't weighed between. If you do cannulations, you create edema and then do the needle knife. That makes it different. That is what I feel.
Secondly, pancreatitis rate with them was much more than what we observe in our practice.
Because those were the patients who were those were high risk patients. There is always a dictum in saying ERCP. Always don't do ERCP in any patient where the indication is loose. Like these patients had a normal bile duct, normal CBD diameter, normal bilirubin, young females, obese, history of pancreatitis, SO dysfunction. These were the patients, those who were the number of SO dysfunction were less. But these were the patients with high risk of patients. And I think they haven't used NSAIDs as a prophylaxis. But normally we see about pancreatitis range is from 5 to 15%.
Yeah, and I think it sort of goes in line with some of these studies as you've come across. I don't know if you have, but US guided drainage as a primary procedure, as some people have proposed. Primarily, the difference is that you're not touching the pancreatic orifice at all. So, that's probably in line with those findings with US procedures that show that, pancreatitis is negated. I think that it's understandable to see why needle knife has lower risk.
Because in one of these sessions, I have heard Dr. Mahadev saying that pancreatitis is not a complication of ERCP. He has seen none. That is what he meant.
Yeah,
I mean,
fair enough.
Yeah, but it is established.
It is what it is.
Yeah.
Any questions?
My question to Yogesh about this ICG dye. So can you throw any advantage in visualizing CBD stones or identifying early biliary leaks, and what is the basic, infrastructure required to use that ICG during?
You have it's a laparoscopic unit which has come up recently. It's basically an integrated IR light which is there in the laparoscope. Stryker has come up with it since it's model 1588. Even Karl Storz has come up with it. You have that system in your hospital. You have 2 of those installed in your hospital. So what it shows CBD stones are like small, you can see CBD stones, or you can even see cystic duct stones. When you are put the ICG light on that, they look just like a feeling defects as you see in the cholangiogram, which we do through our C-arm guidance cholangiogram, which you do. They just look like a feeling defects in the cystic duct or CBD. That is how that cholangiography works. About bile leak, which you're talking of, once there is a leak, you will see all ICG dia there. So I don't think it will work much in the bile leak per se. In bile leak, it has been used as we know that this HIDA scan, which was being done for bile leak. It can show bile leak, but it cannot localize exactly where the bile leak is. The localization will be poor, probably that.
Any other questions, Abhijit?
No, I think from the audience, there are no more questions. Yeah, there are no more questions.
About topical adrenaline, epinephrine.
Yeah.
The picture that you showed a remarkable decrease in edema, pancreatic. Have you ever used it not for reducing the pancreatitis, but for reducing the edema?
Normally, it is my practice that whenever I do ERCP and sphincterotomy, if I see the wounds, I will ask for adrenaline spray. It only not only reduces.
That is for wounds, sir. That is everybody of us is using it for reducing the edema per se. It showed remarkable.
Basically, I haven't used for reducing edema per se, but when I use it for bleeding purpose, there is a remarkable improvement in, cannulation also, and the swelling reduces. It happens, but then it's only transient. It is working like a pancreatic stent, but it is transient. So that's why they say that instead of spray, if the injection of epinephrine was given, probably it would have been better and the results would have been better. That was their conclusion, because it lasts for a longer time.
I think it's a good point that if it's a manhandled papilla which has become like swollen, or if somebody has tried pre-cuts and you're not able to see the head or tail of it, I think spraying adrenaline and taking a re-look is, I think it's a good
then procedure.
Sometimes it's better to re-go after 48 hours rather than, that's because so many gastroenterologists here, rather than to perforate and create complications, always better to retrieve and go after 48 hours. Abhiram is here.
Unmute yourself,
yeah. It gives me great pleasure. It was a very lively session, and I would like to thank the faculty, the Mukevar sir, Saurav, and Yogesh for bringing out such well-studied papers and presenting to us. It's a great pleasure to thank the chairpersons, Abhijit, Vaibhav, Gadam sir, and Qureshi sir for moderating the discussion. And another vote of thanks goes to all the audience who have participated and put their questions and made it good takeaway points for all of us. Another vote of thanks to the support team and IT team who have done all the hard work behind these scenes. So it's a very unique live webinar in the same year in gastroenterology, and thanks to all of you for participating and being part of this. And another thanks to the ASN team, Dr. Desai and Dr. Atish Bansod, for being host to this lively webinar. Thanks, Gadam sir.
Thank you.
Yeah.
Thank you very much.
Thank you so much. I thank the MMC person also, Dr. Vinky Rugwani, also for giving us the credit.
Yes, sure.
And I request Abhiram that the next our DDS activity should be there in month of March, and the other team should now come forward, the younger team.
Definitely, sir.
Distribute the topic to them.
Sure.
Can collaborate with ASN and have some interactive.
For a sincere request from our side, let's meet in center point now.
Yes, it's high time now that we should be having actual activities.
Let's meet face to face rather than on laptop.
Thank you so much. Thank you so much. Thank you, Dr. Gedam, Dr.
Thank
Qureshi,
you. Thank you.
Abhijit,
Good night.
Dr. Bansod, and Dr. Banait. Thank you, everyone.
Thank
Good
you,
night.
sir. Thank you so much. Good night.
Good night.